Listen, when you start examining things like healthy longevity, from a health system's view, you have to be astonished by the continuing and growing burden of chronic disease as it faces people, as you've heard throughout the course of the day. And the level of burden is strong at, 6 in 10 Americans being afflicted with at least one chronic condition. And of course, that likelihood grows with time. But those people afflicted with those chronic diseases are responsible for about 90% of our annual healthcare expenditure. Now, when you look at addressing these things, which is important as we start looking at it from the health system's perspective, you have to start looking at the wide variation that we see in healthy outcomes. What's astonishing is that most of that variation is not caused by variation in clinical care. In fact, as little as 20% of the variation can be accounted in the different ways in which care is being delivered. It gives you some hope and notion that much of the consistency we're seeing building from efforts from the National Academy of Medicine and others to start building out evidence-based practices may be taking hold. I trust that it is. But going back to the variation in outcomes, the biggest influencer of variation is driven by the social determinants of disease or social determinants of health, which may be responsible from anywhere from 50 to, with some assumptions, is 80% of the outcome variation being driven by such factors such as we heard just earlier today, housing and food and nutrition, transportation, social and economic mobility, education, health literacy, and in the case of older Americans, isolationism. But you can really get some confidence that we're starting to see emerge some pretty darn good evidence that if you were to take a direct approach to dealing with these determinants of social needs, we can have an impact. Those interventions really come about in three fashions. The first of which is direct environmental investment, such as housing, such as transportation systems, such as some of the structural things we see threatening the case of care. In fact, when you look at it, when you go into the homes of older Americans doing house calls and the like, one of the things that we see when you start looking at star ratings is that the majority of the gaps in quality are not the result of a physician not writing the order. Rather, it's that once the patient is out of the health system and back home, life starts to occur. And all of these things become threatening. So by direct investment in many of these, we're seeing mitigation. One of the more brilliant experiments we're seeing more recently is direct investment in housing, leading to the improvement in outcomes in both physical as well as mental health. And it comes about because all of a sudden you're creating some stability that leads to better adherence and compliance with the guidance that they're getting from their physician. It's not so much that this is poor order writing, but the threats to compliance that come about by life circumstances. The second area, besides direct investments for the mitigation of the effect of some of these social determinants, is technology and competent and effective health systems that have the ability to improve outcomes by mitigating the impact of social determinants of health are doing so by investments in technology. First, the investments in technology around data management, as well as the investments around analytics of those massive data sets. The combined pools of information from a variety of different levels at the level of the community can help understand the likelihood of need, as well as where local resources are that can intervene. The ability to analyze it allows to project trends and to allow it to track your progress to a desired performance. The final level of investment in technology is around care delivery technology. The use of telemedicine or even telephonic medicine has made a big difference, particularly in mental health, where all of a sudden the issues of transportation and access, or even the adverse influence of stigma, can be mitigated by having that kind of an available communication. And likewise, other forms of care support technology is remote monitoring, where patients at risk can be provided a means to be able to provide data relevant to their personal health status in that way. And finally, these systems operate best, however, when it becomes humanized. And what I mean by that are health systems that have shown themselves to be effective rely heavily on feet on the street. People who are able to go into a particular dwelling or life circumstance to make an assessment and to help close those gaps. Providing those people within the health delivery environment eyes into the life circumstances these people face. And so again, direct investment in technology, and feet on the street are a very reasonable approach to mitigating the impact of social determinants of health on the variability of outcomes. With that, let me turn things back to Kimber.
Great. Thank you, Dick, for those insightful comments. Now I would like to invite Jack Rowe, Mina Seshamini, Cynthia Boyd, and Jim Perrin to the stage. And I'd like to welcome Terry Fulmer, who's online with us virtually.
Okay, Mina, I guess we'll get you at the end. Okay. Well, I'm Jack Rowe. I'm at the Columbia Aging Center, Columbia University. To pick up on a comment that Mahmood said earlier about the importance at this stage in this process that has been initiated by the vision and the support of Victor Zhao, and with a great job of the co-chairs, Linda and John. At this stage in the process, you need to identify the policymakers who can establish the policies or the executives who can implement the programs to turn some of these recommendations into reality. I kind of view this as if this were a lecture we were giving, and slide number 1 is the current condition. And the last slide is the idealized condition. the question we have to answer is, what does slide number 2 look like? How do we start moving forward? At the Columbia Aging Center, we're convened a group to start to think about, maybe at a state level, who are the players, what are the messages, what are the mechanisms to get to them, to try to turn all these recommendations into reality. I think that is a theme throughout this whole workshop, and it's a theme for the conversation that we're going to have here for the next hour or so. We have one person on the screen, Terry. We'll get to her second. And what I'll do is introduce each speaker. We'll hear from them for a few minutes, and then we'll have some general discussion and maybe some questions from the audience. The first person is the most important person in the room. Mina has 50 million elderly patients, and as her role in the Center for Medicare. So Mina, we'll turn to you first.
Great, thank you. Well, it's wonderful to be here with all of you, and I'll just say I'm so excited to be talking about healthy longevity as a goal for the work that we all do to take care of people in our healthcare system. And I say that because more than 20 years ago, my doctoral thesis in health economics was actually on, as people live longer, do they live longer in health or in illness? And in the role that I was in prior to leading Medicare, I oversaw care transformation for MedStar Health, a big health system in the area. And under that portfolio included geriatrics and palliative care, community health, case management, all of which are such critical pieces to this question of how do we make sure that ultimately the care that we want to provide in our healthcare system is achieving the goal of people living longer in health. And I think coming back to what Dick was talking about in his remarks, the social aspects, the socioeconomic aspects that impact our health is so critical to this, as well as really being in tune with culture and what people themselves want from the healthcare system. You know, it's kind of like taking the golden rule of treat others how you would want to be treated to the platinum rule of treat others how they want to be treated, right? And, you know, how can we apply that in our healthcare system? And this is something that we are really putting our shoulder to the wheel on in the Medicare program. You know, our vision for the Medicare program is to advance health equity, to expand access to coverage and care, to drive innovation for higher quality whole person care. And if we are successful with all of that, what will be the outcome? Healthier people living longer. And so the work that we are doing, I think that Dick mentioned behavioral health, you know, where we are working to integrate behavioral health and primary care. For example, we've made telehealth payments permanent for behavioral health for after the pandemic, paying a social worker or a psychologist to provide behavioral health care alongside a primary care provider in an office visit. To work that we're doing to advance more holistic care models. We just finalized a new program, the Advanced Investment Payments, to give funding up front to smaller providers, particularly in rural and underserved areas, so they can build infrastructure, they can develop teams, they can partner with community-based organizations or invest directly in addressing health-related social needs, again, so that we can really view people as people and care for them in a broader scope than just someone coming in for a particular episode of care with a particular ICD-10 code and a particular E&M or CPT code, you know, during that visit, but to think about them as a whole person. You know, these are some examples of the work that we're doing in the Medicare program to try to advance care ultimately towards that goal of making sure that people are living longer, healthier lives.
Thank you very much. Next, we'll hear from Terry Fulmer. Terry Fulmer is the president of the John A. Hartford Foundation. She's a highly respected gerontological nurse, researcher, and educator, and she's been very supportive, as has the John A. Hartford Foundation, in this overall healthy longevity effort. Thanks for joining us, Terry.
Thanks, Dr. Rowe. It's a privilege to be with everybody today, and always it just so exciting, and it really is catapulting to listen to all the discussion today. It really helps move things forward. I love the way you framed it, Jack, when you talked about getting things to reality and the context of social determinants of health, and the way we think about multiple chronic diseases and disorders is something that I think about as really ensuring that we take care of function and that we do it reliably. So again, thank you to the National Academy of Medicine and AARP for sponsoring this. I think the depth and breadth of the earlier discussions that I listened to today really bode well for this. All of a sudden, we're coming together in a way that there's synthesis across the domains of care, across continuity of care, across settings and people. I was re-looking at the cycle of healthy longevity that you all developed for the program, and thinking about how important it is to be co-enablers with work, social, physical, and health. So that's the position from which I comment today. Our mission from the foundation is to improve the care of older adults, and we use all the wonderful science that so many of you generate to do that. And the roadmap is so important because promoting healthy longevity can unleash the potential of older people, as reminded many, many times by this committee and these groups of leaders. So I think that all the goals and recommendations of the roadmap are so very important, but there are some that are particularly important to our work of our grantees and of the foundation. That is the recommendation to address ageism. We can't say enough about that. We're working with the Frameworks Institute. Many of us think regularly about the book, Why Survive Growing Old in America by Bob Butler, and asking ourselves, really, is it now the time we're going to move that needle? Goal 7, with the recommendations to adopt accessible models to provide person-centered. Mina just said that, care for older people with complex needs. And 2 points about that. We've got a lot of models of care, and the Institute for Healthcare Improvement, I'm deeply indebted to them for their work with us on age-friendly health systems, reminds us that you might have models, but you have to be reliable. And I will tell you that with our age-friendly health system 4Ms, it is sometimes nearly impossible to get that set in place in a reliable day-to-day mechanism. So I know we can make progress because we know what we have to do. When we think about the complex care needs, we hear chronic conditions, and that's important. And it's going to be even more important when this report and the Academy begins to drill down on what does multiple chronic conditions mean. It's sort of to me like saying arrhythmia. It's many things to many people. And wouldn't it be better if we knew what we meant? If you're going to have a chronic condition, I would bet that many of us would rather have something like occasional joint stiffness, which is a chronic condition, rather than having congestive heart failure. So thinking about that, drilling down on it. Then goal 8, recommending to develop strategies for making culturally sensitive and equitable care to honor people's preferences in the care community. And I really am so pleased that this report is highlighting that. So the initiatives that we have funded to help support this work, besides the modest amount that we gave for the longevity work, is the Reframing Aging Initiative. I recommend it to all of you. It gives you ways to think about the way we talk about older people, the way we talk about nursing homes, the way we talk about elder abuse, reframing aging. Secondly, the age-friendly health systems, which is really led with great strength from the Institute for Healthcare Improvement. Gratitude to Kate Armate, the president, Don Berwick, Maureen, and all of the team there who have helped us, along with the American Hospital Association, Catholic Health. They are trying to make it real, and they're trying to put it into true practice, causing no harm and aligning with what matters within over 2,900 locations of care. We're working with age-friendly public health systems. We're working with the report that we funded on the national imperative to improve nursing home quality. And finally, we've begun working on diagnostic excellence for older adults, and I recommend the paper that Chris Castle and I wrote for JAMA. So with that, I know I have my 1 minute completed till I'm done, and I want to thank you all for allowing me to participate. I look forward to the discussion. Thank you.
Terry, there were many different recommendations and many different targets here, so I think wouldn't be prudent to say there's one that we should start with. We probably need a multiple warhead approach here.
Yeah.
Maybe chicken soup is a better analogy to multiple warheads.
Well, I think it's pulling those enablers together, Jack, which is such a nice frame.
But if there is a primary goal, it might be ageism, which you mentioned.
I would agree.
It's so pervasive. What do you think, and if you want to answer this later, think about it, that's good, but what do you think is a primary target if we're going to try to have an initiative focused on ageism? What would be your target group or population?
Yeah, it would probably be older people themselves, in that we need to normalize the words of aging instead of laughing the minute somebody says, "Oh, I happen to be a geriatric nurse." People go, "Oh, I'm going to need you pretty soon." And if we could just normalize it, talk about our age. I'm 68. When I say I'm 68, other people don't answer me with their age. So if we could normalize it, that'd be a good start. But back to you, Jack.
You know, I had that experience. I had at a dinner party, a woman asked me what I did, what kind of doctor was I. I said, I'm a geriatrician. She said, oh, I just turned 65. I should call your office and get an appointment. I said, the 65-year-old woman is in my office. She's talking to me about her mother.
That's funny.
You know? Now, there have been several comments earlier about the life course perspective here, which is really, this isn't about the aged, it's about aging. It's about longevity. And to emphasize that, we now are going to hear from a geriatrician and a pediatrician. And we're going to start with Cynthia Boyd, who's a professor and the chief of the geriatrics program at Johns Hopkins. Cynthia?
So much. Thank you so much for the opportunity to share my thoughts. I think it's really exciting to see this work come to fruition, especially its international focus. I think that my clinical work, among several roles, is as a primary care physician in our geriatric practice in Baltimore. And it's really in part through that lens that I thought about some of the recommendations in this chapter, of which there were many, and so just we'll comment on a few. I think one was the importance of strengthening primary care across the life's course and connecting it to a strengthened and robust public health system and community infrastructure. In the U.S., I think this really needs investment. I also think it really needs a team, and I think, as was emphasized in the report, the importance of a team that understands age-friendly principles and is prepared to take care of an aging population is really important. Work by a mentee of mine recently published showed that an average primary care physician would need 28 hours in a day to do everything that was recommended. And while there are many take-homes from that, I think one of them is that we really need to be thinking about what is that team, that interdisciplinary team that actually really needs to be providing primary care, and how do we really partner with a robust public health system in order to be able to focus on the things that were emphasized as important in this report. I think that idea of prevention and thinking about what prevention means across the life course and as we age with the increasing heterogeneity of health status is really important. I think there's going to be some differences in terms of what's focused on for different patients and their families, but I think there are some really important themes: physical activity, social connection, thinking about social determinants of health that really would walk across many of the ages, even if it has different forms. I was listening to Dr. McBride Murray and others talk about our structural inequities. It reminded me of a study from a Scotland primary care database that showed that living within multiple chronic conditions, and I think Terry's point about how we define that and what gets counted is a really important one. But what they showed is comparing people with more deprivation and more structural barriers to health compared to people with the most resources and the least structural barriers, is that multiple chronic conditions occurs over a decade earlier. And I think as when we're thinking about prevention, I think making sure that we're addressing those inequities is critical. I also think, in addition to prevention, the way that the report emphasized the need for a health system that's ready to take care of people when they have functional or cognitive limitations or serious illness is really important. And I thought the way that both of those were emphasized is really important. And another piece that I was really very struck by was thinking about that workforce that's needed in order to promote healthy longevity globally. So a geriatric workforce, I'm quoting, that can adequately care for older people globally. I think that means moving education in our health professional training away from a disease-specific approach to an integrated one that can really both help focus on prevention, but also care for the population that has multiple chronic conditions and functional limitations. I think those age-friendly principles that Terry has brought up, and earlier in the day we heard about age-friendly communities and age-friendly workplaces, which I just loved, so that everyone really knows how to address that, not just people who are focused on older populations. I think two pieces related to education that I would emphasize are that we learn how to function on a team, an interdisciplinary team, that we learn to really how to work together and to value the skills each person brings has to be part of that workforce training. And then especially thinking about the direct care workforce and family caregivers, I think it's not just about education, but it's making those jobs sustainable in terms of pay and benefits so that we retain that expertise and that is developed through that education. Just finally, thinking about how we design the healthcare system to create healthy longevity, and thinking about the ways that we would break down the silos between hospitals, primary care, and public health systems. I think there's a lot of creative approaches out there, and I think the energy that I saw in the report for thinking about them was really inspiring. I'll just mention one example that I thought of as while reading it, which is the work for Capable or Community Aging in Place led by Sarah Zanton and colleagues, which is focused on older adults with limited resources, so people who are dually eligible for Medicaid and Medicare, who are starting out with difficulty in activities of daily living, and bringing a nurse, an occupational therapist, and a handy worker together to work with the older adult to identify what matters to them. And this approach improves function, it improves motivation and self-efficacy, and really addresses disparities. And I think it's really right crossing those bridges between traditional healthcare systems. I loved what Dr. Vega Morales said about the care system and using that terminology instead, and thinking about bringing it to the community and with the person at the center. And just as we think about those approaches, I also think we want to think about ways that we can address things in an intersectional way. And the best example I can think of around social isolation is and cognitive impairment is that, addressing hearing impairment may actually not only help hearing and communication, important in their own right, but may have far-reaching effects to those other conditions.
Well, thank you, Cynthia. You've mentioned several times workforce. We have just utterly failed to develop a geriatric medicine workforce from the point of view of physicians. We're far, far below any reasonable target. And there are lots of reasons for that. Mina won't be surprised to hear that I think geriatricians should be paid more by Medicare, but that's a discussion for another place and another time. But there was a report about a decade ago from the then Institute of Medicine addressing some of these issues, and one of the core lessons there was that we're not going to create enough geriatricians, but what we should be able to do is make sure that every physician who sees older persons, which is presumably everybody but a pediatrician and an obstetrician, they all have some familiarity and competence with the recognition and the management of common geriatric issues, whether they're diseases or syndromes such as fainting, incontinence, confusion, et cetera. And so that obviously shifts the target away from fellowship training and into residency training and medical school training. And I think that it's discussed in the report in some detail, but I think it's worth underlining. Another thing you said that we'll get back to in a couple minutes, but as an early warning, Mahmoud is not the only student of Linda Fried who's here. I am also, and have become indoctrinated into the critical importance of public health. And so the report deals with public health issues as well as acute medical care issues and long-term care issues. And we just can't separate these two things anymore. If we didn't know that before COVID, we know it now. But turning to the earlier parts of the life course, Jim Perrin is the former chairman of the American Academy of Pediatrics, and he's here to give us a perspective from earlier in life. Jim?
Thanks very much, Dick, and Jack. And it's really a pleasure to be here. I am going to give the view from the other side of the life course, but I hope you'll see some of the real connections and aspects of how this flows throughout the life course as we go forward. And I'm partly channeling the earlier comments of Thelma McBride Murray and Dr. Tori Skill, who really set the stage here. Obviously, from the perspective of someone who works with children, youth, and young families, it's really great to see the attention in this report to things like social determinants of health, or as Don Berwick says, moral determinants of health, the attention to the life course, attention to whole person health, the attention to cross-sector collaboration, all things that we're very much working on in child health as well. I'm going to deal with 4 points as I go forward. One is to talk something about chronic conditions among America's children, and to comment that over the last half century, we've seen over a 400 or 500% increase in rates of chronic conditions among children in this country, from about 1.6% in the mid-1960s to about 10% today. Depends a little bit on how you define chronic illness, but that's been a dramatic increase in rates of chronic illness. And from about 1960 to 1980, a lot of that increase was in curing diseases that had previously been fatal. The tremendous growth in our treatment of leukemia, cystic fibrosis, congenital heart disease, etc. I can run through that. But the evidence really is that by 1980, 40 years ago, we had already achieved the large majority of survival among America's kids. And since 1980, the rapid growth in chronic disease has been in a relatively high prevalence, relatively low severity conditions, most of which are not associated with increased rates of fatality, but instead are things like asthma, obesity, mental health conditions in kids, depression, anxiety especially, and neurodevelopmental problems, autism, and related disorders. Those have really been the increasing rates over the last 40 years among America's kids, not something that we had much of in years past. So I think it's really important to realize the change in the health of America's children during this period of time. Second point I want to make is the role of social determinants or moral determinants, especially poverty, but other adverse childhood events in America's children. We know that there's a high rate of that in far too many kids in America. We have the highest rates of poverty of any industrialized country among children, and we know any way you cut it, poverty is associated with lots of bad outcomes, including lots of bad health outcomes, and really good evidence to support that relationship between adverse childhood experiences and a variety of diseases that start with mental and developmental health problems, but go on to be the diseases of cardiovascular disease, pulmonary disease, liver disease, etc. later on. We also know that there's some substantial racial inequities in these findings, that the rates of chronic disease, especially the ones that are new common ones, are much more common among low-income kids of color than they are in the rest of the population, a dramatic change at that level. And similarly, we know that adverse events, especially poverty, is of course much more common among kids of color in this country. Third, we all know, and NAM has been really leading in getting this information out, the increasing rates of decreased longevity among Americans of working age. We're the only industrialized country in the world that's actually had longevity decrease rather than increase in the last decade or so. And the reasons of that, by the way, that starts at about age 25, if you look at the data on the rising rates of mortality among Americans. So it's not something just of 45 and 50-year-old people, it's younger people. And it's, by the way, not much for people over age 60, who seem to have really good health care and health status compared to most other industrialized countries. But up to age 60 it does. And for the younger people, the people in the 20s and 30s, it is primarily deaths by suicide and deaths by substance use and substance use disorders and a few other things. But by the time you're in your 40s, there's much more cardiovascular disease, pulmonary disease, liver disease, metabolic syndrome diseases, and so forth. So the point I'm really making is we have created an increasingly large underclass of America's children who grow up to be an underclass of people who are really not doing well in their health care during that period of time. Last comment is a little bit about healthcare systems, since that's really the topic of this particular panel. And to say that there are 2 or 3 elements within that I'm interested in. One is, given the rising rates of chronic disease among America's kids, we are doing a lot more team-based care in the context of chronic disease management. Not enough, because most people develop their teams based on philanthropy and not based on any kind of payment arrangement from Medicaid or public or private sources. But beyond that, and I'm really thinking so much of what Cynthia said, in primary care we are also moving a great deal toward much more team-based care, heavy integration of mental and behavioral health as members of that team, a good deal of emphasis on prevention. And we know, when I talked about the high rates of suicide and such things, that there are opportunities to prevent them if we really deal with them easily. And the last I'll say about this is, there was a very good report from NASM about 3 years ago called Vibrant and Healthy Kids, which Kimber had some role in getting it started. But it does lay out a frame for what we really can do differently and what kind of progress we're trying to make. So thanks very much, Jack.
Thank you, Jim. You know, there have been several comments about the social determinants of health. And Henry Cisneros started the conversation about compression of morbidity. But just to emphasize one of the things that you've said, that the experience in lower socioeconomic groups is that there's actually a decompression of morbidity, not a compression of morbidity. And that has huge implications for every part of our healthcare system. Another point is that while this is about health systems, the highest return on investment in terms of health, in terms of life expectancy and disability-free life expectancy and dementia, is in education. So, I mean, if we really want to take the long view here, education is essential. It's just a terrific investment. Terry, let's go back to you. You mentioned nursing homes, and that was one of the specific areas that we talked about 6 different parts of the healthcare systems issue in the report: chronic conditions, public health, healthcare delivery, long-term care, the workforce, and geroscience. So let's get to the long-term care piece a little more. I know you've done some work in this area. NASM has had a recent report on quality improvement in nursing homes. Tell us your thoughts about that.
Thanks, Jack. And I'd like to say overarchingly, one of the things that we've worked on with a lot of smart people is talking about the age-friendly ecosystem, which includes public health, acute care, healthy cities, age-friendly communities. And that work's available at the Age-Friendly Institute in Boston, and many of you in the room helped with that. We appreciate that because it has to be a continuum across settings and across people. So nursing homes, we like to save people in our society, but we don't like to take care of them. And nursing homes make that very clear. COVID, of course, we saw what happened. So I think that a lot of people are listening. We have the ear of wonderful people at CMS and at Joint Commission and other places where they have levers. As Jack said, what are we going to do? What are the actions? We funded that report and then immediately funded a second grant that Leading Age, the organization that represents not-for-profit nursing homes, so that they can take the 7 recommendations and get them over the finish line, which is hard. That's many people, including people from Brookings and from an array, AMDA, all the organizations are working very hard on that, and everybody's welcome into that. The last point I would make is that of the 1.2 million people who live in nursing homes, half of them are there because of our payment structure and the way in which you must go there to get your rehabilitation. That's about 500,000 people who might do just as well as home. So at home, get their rehab there. Then you have 500 million people in nursing homes, and you could maybe use small houses like Greenhouse to take care of them. I know a lot of people are working on that. I believe we did an analysis of which states have the fewest number of nursing homes and what the proportion of nursing homes to people are. And it turns out Vermont has a very good chance of adjusting the model most quickly. So stay tuned. We'll be watching.
So do you think the targets for these initiatives that came out of this report, which sound like they're aligned with the roadmap recommendations in general, with respect to long-term care, are the targets federal targets? Are they state targets? Are they the nursing home industry? Where's the target?
You won't be surprised to hear me say all of them, Jack, and everybody's watching carefully to see if we can get simple things done, like can we get a list of the chief medical officer in every nursing home in this country? It's not available. So there are some simple things we can do. It's in complete alignment with the roadmap book, which I have in front of me, and looked at what we said about nursing homes and think that it's completely compatible. And what we want to do with our work from that Academy's report is just use this longevity challenge as a way to accelerate the progress that we need to see. We can do this. Remember, and you and I wrote a paper about this, Jack, nursing homes were primarily built in the 1960s, 2 beds, shared bathrooms, an infectious nightmare. So it's just time to take a deep breath and say, what can we do to make this better?
Yeah, you make me feel like Sisyphus a little, Terry, reminding me of the early days, because things haven't changed much. Keep trying to push this rock up the hill. It keeps rolling down. Do you have a thought about the long-term care workforce issue? I mean, because it seems as about 18% of people in healthcare quit their jobs during COVID, but about 15% of them went back. They just found something. They didn't want to work in the emergency room anymore, or an ICU or whatever, but they wanted to be in healthcare. But they didn't come back to nursing homes.
Right.
And so the long-term care workforce got depleted.
Mm-hmm.
Any thoughts
and
about that?
By the way, when I do rounds in the hospital I round in here in New York City, as I turned and I noticed new people, I said, where did you used to work? And they said, nursing homes. That's a problem. So I think that what could we do in nursing homes? I'm optimistic about robotics. I've seen good work in Japan and Singapore and others where they're working hard to use robotics so that human beings don't move the trays and linen, for example. So robotics, technology, we already heard from Dick Migliori about the use of tech so that you could do consultation if somebody has an unusual symptom in a nursing home. Carting them away in an ambulance to go to an emergency room is a very bad idea. So tech, robotics, and again, teamwork, making sure that people, Jack, you were on the Future of Nursing report, making sure that people practice to the top of their license, ensuring that everybody is engaged in the way that is most using them to the fullest.
Yeah, and for those of people interested in this, the Academy is has come out with two reports on the future of nursing with specific targets. Very well received. The most downloaded report in NAM history was the first one. It crashed the system, and they're very, very much worth looking at. Cynthia, let me go back to you. One of the things that you said was public health, and you're a proponent of expanding the walls of the traditional healthcare system to include population health, public health. What would that look like? How would you do? What would you do to do that? What would it look like?
Yeah, it's a great question, and I'd be interested in what others on the panel would say. But I think some of the things that I think about are making sure that we actually have the connections to organizations that are in the community, doing things related to public health. So just as an example, so that we, when we have patients who are in affordable housing, right, and we're trying to think about things like social connection and physical activity. One of my colleagues, Thomas Cujo, is really interested in that and has been doing qualitative work around Baltimore. But whether or not affordable housing communities actually have someone who is there as like a service coordinator to actually be providing services is highly variable. And so thinking about how we make sure that the health, like the primary care and the hospital and the long-term healthcare systems, how are we actually connected to those places in the community? I think building those bridges and making sure that we're talking to each other and that not operating as silos would be one of them. I think one of the things that's toughest about it, right, is the way our incentives are right now, is that our incentives often are really siloing us either, within the healthcare system or without it. But I think there are some innovative models that are trying to evaluate things. In Maryland, we're part of the Maryland Primary Care Program, or MDPCP program, where in the next wave, we're going to have community health workers that are directly linked to our primary care practice. And,
I see. As part of the team.
As part of the team, yeah. And it's just getting started for us. So, but I think really thinking about models where the incentives are such that we are thinking about all that happens that's outside the office where you are, like what Dick was saying about when patients are out there living their lives, and that we need to kind of be meeting people where they are. But I think it's important that the incentives be aligned so that the partnerships
and
can
of
get
course
built.
Dick also mentioned housing, and United Healthcare I think was the first large commercial payer, certainly, to move in that direction. Jeffrey Brenner from the Camden Coalition did some of the initial work in that, which he then continued at United Healthcare. Mina, what is Medicare's role, if any? Medicare it's a government program. It's got a very specific charge. It's legislative. It can't just sort of go out and do stuff it wants to do, even though a lot of people might want it to. It's got rules that it has to. I spent 6 years on MedPAC, and so I'm familiar with some of those restrictions. But what is the role, if any, of Medicare in this interface of healthcare with public health?
I think there is a huge role for it. You raise a point that there are Medicare laws, right, Medicare statute, that kind of set the framework for the Medicare program, and then within that, where we can then drive change with regulations. And the third aspect of it is then partnership on the ground, and that's something that I feel very strongly in. Again, coming from my role, taking care of patients, leading care transformation on the ground, where can I now in my role drive some of these incentives, some of these models in partnership with those who are making them come to life and become a reality on the ground? And I think that's the theme in which I look at CMS as a large public health agency. From paying for over-the-counter COVID tests, Medicare did not pay for any over-the-counter tests or services in the history of the program until we put in place payment for over-the-counter COVID tests for the PHE. That has huge public health implications. Where we have increased payment for at-home vaccinations. Again, something that happened with the pandemic where we realized we have vulnerable people who can't go, leave their house, go get a vaccine. They're the ones who need it the most. Using our levers to encourage that kind of care, moving it away from traditional settings. And then how do we garner those learnings and lessons moving forward as we think about vaccinations, as we think about where we're, incentivizing, paying for things, and doing so in a way that isn't just, let's just drop some money here and then step back and see what happens, right? I mean, Terry and I have had many conversations as we are rolling out, for example, this program to provide investment dollars up front. The key is going to be that those providers have a community within which they can partner and really put those dollars to work, where you are then partnering with community-based organizations. So you're addressing the food, the housing, the transportation needs of your communities, where you are creating a team that has diversity, both diversity in terms of the experiences that the people themselves have had, but also their expertise, right? Where you then have a social worker, a community health worker, a physician who are all coming together to really provide that 360 care for people. And that, partnered with public health, is what is going to keep people healthy. So, we partner very closely with HRSA. We talked about workforce. Thinking about where we can leverage our GME policies, prioritizing rural and underserved areas with work they're doing on workforce grants. Thinking about partnerships with the CDC, where there are grants available there. Can we braid what we're doing in CMS with what CDC can bring to a community? So you're lifting all aspects of a community together. And I think that's where we're really going to achieve then this healthy longevity, and where we're going to take care of communities in a way that makes sense for that community.
Thank you. That's terrific. Jim, you mentioned chronic diseases. And staying on this public health theme for another minute or two, some scholars at Columbia, and I'm sure many other places, have shown very direct relationships between air quality and asthma, which is one of the items that you mentioned as a dramatically increased prevalence over the last couple of decades. There's a pediatric enterprise in the United States moving in this direction of public health as well as acute care in pediatric training and in policy approaches, programmatic approaches?
Sure. Two or three things. One is, pediatric hospital beds are not filled with acute care. It's all chronic disease. So if you go to Morgan Stanley, it's going to be 80% of the inpatients are kids with some kind of a chronic disease. So we're really starting to train people that way. But more specifically, getting back to some of Cynthia's and others' comments, I actually started working with community health workers 45 years ago when I was running a migrant health program in upstate New York. And I've always worked with community health workers, and I learned so much from that experience because they know so much more than I know about community. So if I have a kid who's living in public housing and has asthma every time she goes to the bathroom because of the mold in the bathroom, I don't know anything about getting her better housing. But I ought to have someone on my staff, a community health worker or others, who knows how to sort of direct her the right way. I'm not sure we're still going to find her housing because that's such a huge problem in general nationwide. But I think that the point is that really this notion of moving to team care, which is what we're all trying to do in primary care but also in subspecialty care, it brings in members of the staff who are capable of building that interface with the public health system and with other services.
And I also think there's an opportunity for education in nursing and in medicine. I remember when I was president of a medical school, the first day of every academic year, I would give a welcome to medicine talk to the new class. Great fun. And one year, the student asked me, he says, Dr. Rowe, what's the difference between medicine and public health? And I told them, I remember very clearly, I told them, I said, medicine is the application of scientific method to improve the well-being of an individual. Public health is the application of a different set of tools to enhance the well-being of a population. You're here to learn the first one, not the second one. That was the wrong answer. That was my answer, but that was the wrong answer. And if I were asked that question now, I would answer it differently. I mean, I think, but I'm not sure every dean of every medical school would get the question right. It's what? He should ask for his tuition back. Thank you, Victor. That's very helpful. So it's an important opportunity, given the emphasis of these issues in the roadmap, for us to press and to identify the targets of the pressure. Mina, you mentioned in your remarks equity. How does equity is a big problem, and even within the elderly population, there's a lot of lack of access, et cetera. Even cost. Some people say Medicare is a high deductible health plan, right? It's $1,000 if you go to the hospital. So how can Medicare deal within its population with the equity issues?
Yeah, that's a great question, and it's certainly a central topic. I think the pandemic has really brought to light a lot of the disparities and inequities in our healthcare system that we really have an imperative to address now. And how we view equity, taking a step back, what is health equity? We view health equity as everyone having a fair and just opportunity to attain their optimal health, regardless of their socioeconomic status, race, ethnicity, sexual orientation, gender identity, geography, language, culture. There are, as you all know, myriad of factors that go into someone's health status and their ability to access care. And so enabling everyone to have that opportunity to achieve their optimal health, I think within the Medicare program requires us, number one, to have equity be front and center of every single thing that we do. When the system is cracked and broken, it's not the MD, PhD who has difficulty navigating and kind of figuring out what they need for themselves or their family members. It's people who maybe don't speak English, who don't have family support, who are working multiple jobs. And so front and center, making sure that our system and our programs are working in the most effective way that people can navigate and they can utilize is really critical. So a tangible example, we have the Medicare Savings Program, which provides support, financial support for lower income seniors. And when I took my role leading Medicare, I learned that only half of eligible seniors were enrolled in this program. So you have a wonderful program, right, that will address equity. It's going to break down financial barriers. And it really all comes down to how things play out on the ground in that last mile. So we've done concerted efforts. I did, open enrollment for Medicare, media tours, always mentioning there is this program. Find out if you qualify. We increased enrollment through one open enrollment by about 800,000 people. We are taking policy actions to expand ability to enroll. And so I give that as one example of where you have specific policies that can target issues of disparities and issues of inequities. And it has to be married with true, practical, on-the-ground operations so that you make those things a reality. And that's why really embedding equity into everything we do. And it comes back to what I think is really front and center in the roadmap about those partnerships, about the call to action, so that it's not just, oh, well, this person over here is going to tackle this aspect of healthy longevity, and then you point to this beautiful, thing on a bookshelf. It's really about embedding these principles in every single thing that each of us are doing every day and taking that with us when we then partner across the ecosystem, because that's ultimately how you're going to drive this kind of change.
There's one aspect of the roadmap that we haven't emphasized enough, I think, and that is that this is a global issue, okay? We're talking about Medicare. We're talking about healthcare in America. We're talking about, redoing the long-term care system in the United States. Well, in low-income countries, they don't have a long-term care system. So that's a little bit different situation.
They do. It's called Mothers and Sisters.
Yes. Okay. They don't have an institutional long-term care system. Thank you. Or they have very little. And access is very limited. And insurance for it is very limited, as it is in the U.S., of course. I do think it's important for us, as we try to figure out what to do here in our system to move forward, that we also need to understand that this is a global issue and we have some responsibilities with respect to that. We have the great ally of our leader from Singapore, but Singapore is hardly a low-income country. So, it may be not U.S., but it doesn't necessarily give us that insight into low-income countries. And this is one of the places where our faculties of public health can be very helpful, I think, to us, because they have expertise in that area. And it also makes us turn now to the WHO or the UN or some of these organizations, which have been partners, and the WHO now is the Decade of Healthy Aging, which includes low and middle income countries as well as the OECD. But I do want to just emphasize that because I think it's an important part of our overall effort here. I want to make one last comment on long-term care, and that has to do with long-term care insurance. Long-term care insurance is a grossly underdeveloped product in the United States. Less than 1% of the people who might have it. There's a simple reason for that. The young people don't think they need it, and old people can't afford the premium. And there was a portion of the Affordable Care Act, which is called the Class Act, which Senator Kennedy proposed, for a voluntary long-term care system. But you can't have a voluntary long-term care system for the reasons that I just mentioned, that young people don't buy into it, so they don't contribute. Old people can't afford it. So the law said that if the chief actuary of Medicare deemed that the Class Act population was not actuarially sound, that the Secretary of Health could eliminate the program, which is what Kathy Sebelius did, because that was the instruction from the chief actuary of Medicare. And I think that was appropriate. But maybe the roadmap, maybe the shining light on the long-term care because of the lens of COVID, all the other things that we've said about maybe this provides us with an opportunity to think about how we could, in fact, get some sort of a mandatory long-term care insurance program in the United States. It would, in the long run, make a huge difference. Any thoughts on that? Terry, do you have any thoughts on that? Or Mina? Do you have I don't know if you can even comment on that. You may not be, Mina may not be permitted to make a public comment on that, but I think we'll give you a pass on that. But Terry, do you have any thoughts on it?
I'm so glad you brought it up because that is an arena that we've just barely re-examined. It went south when it first came out because the companies who were selling the long-term care insurance policies closed. We did not get out of the gate strongly, and we could. It's always worth re-examining it again, and I'm really happy you brought that up. The only other group that we haven't talked about today specifically is the Administration for Community Living and all the things they're doing with the AAAs, with CMS, with the public health system to help people get home instead of and get their long-term care support, regardless of whether it's in the institution or not. And I just want to thank that group who's worked so hard on this as well.
So, Kim, do you want us to take questions from the audience if we have some? We have 5 minutes?
Jack, why would you?
Yes, Victor, Dr. Zhao. Do we have a microphone? Okay, we have somebody coming with a microphone.
Jack, a quick question is, why
Yes.
would you use insurance as a mechanism for long-term care? Wouldn't we do a better job financing it through another model than insurance?
Yes, you can finance it in a whole variety of ways. You can just give everybody universal coverage, and you can have block grants. You can and let states manage it, or like they do in Canada, different sections of the country manage it in their own way. Germany has a different system. The Netherlands has a different system. But since we already do have a long-term care insurance kind of thing, sort of quasi in the system, if you made it mandatory, you have an infrastructure that you can build on. You have some laws that regulate it, and but you could do it in a variety of ways, I think, easily. And we kind of have it in Medicaid, but you have to be Medicaid eligible, and you have to you have to kind of spend down your assets, if you will, which is not a very clever strategy. Yeah. Yes, Victor.
Great panel, and I must admit I'm quite encouraged on many of the comments we made, particularly Mina, about the cooperation on the ground and collaboration. It's really exciting. I'm a physician. I hear a lot of diagnosis today. Even report makes the right call. We talked about social determinants, integration primary care with public health. As I look back, the IOM and NNM has written reports since 2011 about future public health, about the importance of integration primary care with public health, 2013, about population health, and about social service and medical service being integrated. Hasn't happened to date, right? So yes, that's not a new concept. I think increasingly we all agree that it needs to be done. The question is how. So Cynthia talked about misalignment and incentives. I think we have a structural problem and misalignment of mission more than incentives, because incentives argue that you should keep doing the same thing. If I move the money around, you would work better together. But this is where I want to ask you, Mina, right? I'm envious of Singapore. Not a big country, but they have one system, and the one system is under Ministry of Health, where the hospitals work under the system, the public health works under the system, and of course they still have GP issue to deal with, but still, aside from the small amount of expat hospitals, they can actually together say, we are going to achieve together population health. How do you think we can do this in this country? Where do we have to rise up to a strategy whereby we can say, after all, CDC, CMS all under HHS, but then there's social services. There's all these, as you say, statutes and fragmentation that prevent us from thinking about the big picture that we've been talking about this entire session, that we've been writing about for quite a few years. How do we move this thing forward is the question.
Well, it's sort of the question is the roadmap 2.0, right?
We had a roadmap on this one too. The question, what's a roadmap?
Yeah. Right? Was it Justice Brandeis that said the states are the laboratories of democracy? We might find a state, a particularly forward-thinking state with a particularly forward-thinking governor, whoever that might be, I don't know, and she or he might figure this out and develop something to supplement the existing federal structures and enhance the stuff we're talking about. It just seems to me that something like that might work, maybe Oregon, someplace, I don't know, might work better as a start than trying to start at the federal level where right now, nobody's talking to anybody on the other side of the aisle, as far as I can tell. So it would be extremely difficult. And it would be very costly to do it on a national basis. I don't know, Mina, what do you think?
I mean, I think that one key difference from 2011 and now is COVID pandemic. Oh, did my microphone just cut out? No, it's there.
No,
okay.
We're getting the hook, but keep going. Go ahead.
Where now public health is much more front and center in people's minds than ever before, where health inequity is much more front and center. I mean, these are words that have become part of household conversations in a way they weren't before. And I think that is the difference, that the onus is on all of us, to be quite honest, to leverage, to really drive change. You know, I obviously cannot speak to, are we going to become Singapore, right? And I think there are ways that our system has developed that is that uniquely American way. And so how do you take the benefits of that, like, you know, the laboratory and the innovation and the ability for care to be local? When I led community health, I would always say, what's the first word in community health? Community. You know, how can you leverage that innovation, that local feel with that ability to integrate and kind of break down silos and not have things be fragmented? I think that's what we're all trying to hit, that sweet spot, you know, in the work we're doing. But where we have galvanized true interest more generally around public health and healthcare, I think is what is ultimately going to make a difference this time around.
With that, I want to thank our colleagues and thank all of you for your attention. And I want to thank Linda and John and Victor again for their leadership. Thank you very much.
Great. Thank you, Jack. Thanks, everyone, for a very stimulating and expansive conversation. Thank you so much. Now I'm going to ask you